Thanks for listening to the Wild Health Podcast. For the foreseeable future, you're not going to hear our normal intro or outro here. We're going to be releasing episodes very frequently as things are changing. This channel will be used for a very specific purpose. Number one, to communicate with our patients. We're somewhat overwhelmed, and the more we can communicate breaking news and recommendations from us to our patients all at once, the better. So if you're a patient, we're here for you if you need us, but if possible, please tune in here so we can both keep you up to date and conserve our time for the most critical tasks. Feel free to share this with friends and colleagues as well. Number two, we've organized as a group. We have infectious disease specialists, ER doctors, critical care doctors, and in total dozens of MDs, PhDs, and frontline clinicians who are going to be constantly evaluating the news and emerging evidence. We're then going to summarize and translate that for you here every day on the podcast. The speed of change with the circumstances will make us look foolish at times, but we're committed to pouring all of our resources and energy into doing what we can to help and make a difference. You can also follow our updates at wildhealth.com or our Instagram account at wildhealthmd. And if you're a patient, we're here for you. Please tune in here for the updates and let us know how we can help. Good morning, April 14th, Tuesday. As of yesterday morning, Worldometer reported 580,000 cases and 23,252 deaths in the United States, and approximately 2 million cases and 118,000 deaths worldwide. The case fatality rate in the United States is around 3.87%, but that is probably a gross overestimation, as we will discuss a little later, based on some data out of Germany. Data from the Financial Times shows that the rate of increase in cases in the United States has slowed down since last week, a sign that the outbreak could be peaking. Over the weekend, the United States became the country with the highest coronavirus death toll, surpassing Italy. The death toll in the United Kingdom continues to follow Italy's path and may end up higher. Meanwhile, Italy reported its lowest number of new deaths since mid-March, with a little over 400 deaths in the past day. The rate of new cases continues to fall in New Zealand, Norway, and Australia, several countries that acted early by quickly locking down.
In New York, the coronavirus death toll has surpassed 10,000 cases. In his daily briefing this morning, Governor Cuomo reported hopeful signs that the outbreak has indeed peaked in the state. The number of patients admitted to the hospital for coronavirus dropped by 17% in the last day. The number of coronavirus patients in the ICU also dropped slightly, as did the percentage of people testing positive for the virus. Governor Cuomo warned, however, that these trends will not hold if New Yorkers do not continue to practice social distancing. The largest hospital network in Michigan announced it would be launching the most expansive serology testing study yet to look for coronavirus antibodies that may signal immunity to the virus. Michigan has the third highest number of cases in the country after New York and New Jersey. The health system will perform serological testing on blood samples from 38,000 of its employees, as well as thousands of additional physicians and affiliates, although participation is going to be voluntary. Researchers hope to use the findings to help public health officials determine the true scale of the outbreak in the community and answer the lingering question of whether or not people with immunity can return to work, especially in the healthcare setting.
Yeah, I think that's going to be a critical study. I'm really excited to hear that they're going to do this. Hopefully they're going to do this pretty quickly to give us some really good information, because this information is going to be extremely important as we talk about how to open back up, what's safe and what's not safe. There was a study that came out several days ago out of Germany that gave us a little bit of this data and shines a little bit of light. It was in a town called Gangelt. So this town was on the border and was hit pretty hard because of a festival that they had in February. So a lot of people gathering before we really knew what was going on, and they were some of the first deaths in Germany. So what they did in this town, is a small town of 12,000 people, they actually just randomly chose 500 people, did serologic testing, and they found about 15% of the people either had an active infection or had antibodies present and had been exposed. So this told us a few things. Firstly, in this town where there had been a lot of exposure, they didn't really necessarily have what would be called herd immunity, with just maybe 15% exposed. To be fair, though, we don't know exactly the sensitivity and specificity of the serologic tests. It could have been that more people were exposed. Maybe that's the only people that produced antibodies. We don't really know exactly the operating characteristics, but let's just assume that that was the percentage of patients who had been exposed. And let's just assume that they have immunity, which we think they do, but it's still a little early to tell for sure if they all have immunity. So we think this is probably means that the herd immunity approach, for example, that Sweden is kind of taking right now, it may be a long time before we get there. 15% of people will definitely slow the spread down if 15% of people in a certain population have immunity, but it's not going to stop it. Kind of the best estimates I've seen are it will slow the spread by about 20% with that kind of immunity in the population. The other interesting thing from this is the mortality rate. So the mortality rate was much lower. And we've been talking about this for a while, that the mortality rate is probably not, the CFR, the case fatality rate is probably not as high as we're talking about it and reporting it to be, for example, over 3%, like I read earlier. Those are of the cases that are tested, but there's a massive problem with testing, and so the denominator is an issue. We don't know how many people were actually infected. And if you look in this study, their case fatality rate, the mortality, was about 0.3%. So still several times more lethal than the flu, but 1/10 as lethal as we thought from some of the numbers. So some good news there on the mortality, maybe some bad news as far as being able to have herd immunity rather quickly, but still important numbers to note as we try to figure this problem out going forward and what to do. And I'm really excited about that 38,000 employee study out of Beaumont Health.
Yeah, that's going to be great. I'm really encouraged by the reduction in the case fatality rate that we're seeing out of that Germany study. I mean, I think this is what you and I have talked about previously, Matt, and we've sort of expected to happen, is that we just see that case fatality rate continue to go down and down. Unfortunately, we've been seeing the case fatality rate go up and up in the US, and that's just because we're still on the steep portion of the curve. So people are getting sick, and it takes them a while to die, frankly.
But one thing we should say about that case fatality rate, though, is I personally do not believe, so this 0.37%, this is in one particular town in Germany. So we know that the demographics are not going to be the same there as, for example, in the Deep South and some of the issues we're seeing with certain socioeconomic classes and how this is hitting people who may have other comorbidities really much harder. So I think that's important to point out too. We don't want to get too hopeful saying the case fatality rate is just a few times worse than the flu. This is going to be different population to population. So that's why I think the Beaumont Health will also be informative, but again, we'll only be able to apply that to similar demographics as they test, which they're testing physicians, other healthcare workers, and the demographics for those, the fatality rate for those people will be different. And it could be lower because these are very healthy people, or it could be higher because these are people who may be getting a large bolus because they're in a hospital setting. So I don't actually know which way that's going to go. I just want to bring up the important point that the case fatality rate will be different in every community probably, but we're starting to at least get a range of what it could be.
So Matt, I want to talk about a study that was just recently released in New England Journal of Medicine on April 10th. And this was on the study Remdesivir, which has gotten a lot of press, and a lot of people are really excited about it as a potential therapeutic for COVID-19. So I thought it would be good to sort of spend some time actually and dig into the study some and talk about it amongst the two of us. So I'm going to tell you about the study first, and then we'll kind of talk about some of the implications. So Remdesivir is a prodrug that gets converted in your body to an adenosine analog, and it basically interferes with viral replication. So the way the drug works is it gets into your cells and it stops the replication of the virus inside of your cells, so that basically you just get a lower viral load. It was made by compassionate use by Gilead, which is the company that makes it. It was initially made actually for Ebola as an antiviral, but has since people have become very interested in it for COVID, obviously. And it's been made compassionate use for over 1,700 people so far. So a lot of people have actually gotten this drug. Unfortunately,
Hey, Mike.
Yeah.
We should probably explain what compassionate use means. It doesn't mean that the drug maker is just super compassionate and nice. It just means it's an unapproved drug that they're making available for these studies.
Exactly.
In dire circumstances.
Exactly. So a lot of people have gotten it. Unfortunately, in this study, only 53 patients were actually reviewed. So they looked at 53 patients, some in the US, some in Italy, some in Austria, some in Spain. And of those patients, they were mostly over 50 years old. and the majority of them were ventilated. So 64% of them were ventilated. So this is a pretty sick group. In fact, a few of the patients, I think it was 3 or 4, were actually on ECMO when they were enrolled in the study. ECMO is when basically you're hooked up to a machine that is literally oxygenating your blood for you. So your lungs are not even functioning at that point. There was no control group. There was no randomization. There was no patient matching. So unfortunately, it really is just an observational study saying, hey, if we give these patients Remdesivir, then what kind of numbers do we see? What kind of outcomes do we get? Which is probably one of the least beneficial studies from a scientific standpoint, because we're not comparing it to a control group, which is really the most important thing. So in the study, like I said, there was a wide range of illness. They had 64% of the patients were initially on a ventilator. 13% of them were getting basically endotracheal tube positive pressure ventilation. So these are things like BiPAP and CPAP that you may have heard of, as well as about 18% that were on oxygen therapy, and then 4% were on room air. All of them were admitted to the hospital, so they're all sick enough to at least stay in the hospital. In the study, 68% had clinical improvement. They documented clinical improvement as basically having an improvement in oxygenation requirement, or maybe you were well enough to get discharged. As far as mortality, they had a 13% mortality, which is way lower than what we're seeing from most of our other studies, epidemiologic studies, as well as other control group studies. 13% is lower than what we're typically seeing. On average, we're seeing somewhere between 20 and 25% mortality of patients who are admitted to the hospital. And the problem with that is, the main problem is that the study was published before they got data back on all of the patients. So 10 of the patients are still on ventilators, and 3 of them are still on non-invasive positive pressure ventilation. So if we assume that all those patients that are still hospitalized on ventilators and positive pressure ventilation die, then the mortality would now be 37%. So we're talking about over a doubling of the mortality, almost a tripling of the mortality, just by the patients that are still in the hospital. So in some ways, one of my first questions is, why did they already publish this study? Why not wait and get the completion of the data? And I find that really frustrating. And that's actually been fairly consistent with a lot of our studies so far. If you actually dig in and try to figure out what the average mortality rate is for a patient who's in the ICU, it's almost impossible to find, because all of these studies, they're being published, with the exceptions of the ones that are out of China from early February and January. Over half the patients are still in the hospital, so you don't really know what their outcomes are. So when we hear these numbers like the ICU mortality is anywhere from 20 to 80%, or the ventilator mortality is upwards of 80%, the problem with all of that data is that it's incomplete. So we're trying to look at incomplete data sets. So let's put that aside for a second and try to make sense of the outcomes of the study and whether there's any true benefit or not, compared to what we expect the outcomes to be for our patients who are not on Remdesivir. So let's remember that number of 13% mortality. All right, we'll just go by mortality, for example.
You mean 13 to 37%
right.
mortality?
Well, let's give them the benefit of the doubt for a second. So if we look at that 13% mortality, and we compare that to a control group from another New England Journal of Medicine article. This was a trial of leponavir and ritonavir in adults hospitalized with severe COVID-19. In this group, unfortunately, the patients were a little bit healthier, but in some ways that might actually play to Remdesivir's benefit. So these patients were actually healthier in their control group. Only 16% were ventilated as opposed to 60%, right? Although 18% were ventilated by the end of the study. 67% were on oxygen, and 17% were just on room air. Their overall mortality was 25%. So actually way higher than the Remdesivir study, even though the patients are generally healthier. So obviously the big problem here is that we don't have all the data back from the Remdesivir study. So 25% is better than 13%, but it's not better than 37%. There was another study that came out on March 13th in JAMA of Internal Medicine. This was risk factors associated with acute respiratory distress syndrome and death in patients with coronavirus disease 2019, pneumonia in Wuhan, China. The nice thing about this study is that in this study, the data was complete. So for the most part, all of these patients had been managed. They were either discharged or they got worse. You knew what happened. The issue on this study is that the average age was similar to the Remdesivir study of 51, which is important because age is associated with mortality. But the problem is the patients were fairly sick, but hardly any of them got on a ventilator, which is interesting. So their mortality was still 22%, but only 2.5% ever got placed on a ventilator. So that means quite a few patients were dying off ventilator. So we don't know why that was. Was that because they had a do not intubate clause? Was that because they didn't have enough ventilators to go around, or they were just managing all their patients on non-invasive positive pressure ventilation? So where are we now? What we know is that remdesivir, at least in this study, shows that there's somewhere between a 13% and 37% mortality if you give the drug the way it's described by Gilead. Unfortunately, we don't know exactly what that's going to end up being. We do know that a lot of the patients in the critical care group improved. Patients who were not ventilated, all of them did fairly well. There was only one patient that died in the positive pressure ventilation group, and only one of the patients in the positive pressure ventilation group went on to get intubated. So the question really, in my mind, stems on how are those patients that are still intubated going to do? Are they actually improving? The problem is, though, even if we had that data, and even if we knew that they were all going to improve and the mortality was 13%, we still don't have a control group. Some of these authors are affiliated with Gilead. So they are, whether they're cognizant of it or not, there is motivation for the drug to do well. And if they choose people who are improving in the ICU, who are intubated, for example, then those patients are more likely to do better. And if there's no control group and there's no definition of how the patients are doing when they initially put them into the study, then we don't really truly know how to interpret the data. So this is maybe more of an exercise in talking about critical thinking with papers than it is on actually getting specific information from this drug, because unfortunately, I'm not sure that it's really convincing me that there's a significant benefit.
Yeah, and you mentioned that the Gilead, the potential that Gilead is involved, and they're very motivated for this to work. I mean, I guess what I'll say to that is we're all very motivated for this to work. So it's like there's so much hope. Everyone wants all of these treatments to work. There's never been a more important time in history to have control groups. And that's one of the things that I've been taking away from looking at all this research in the last week. We're all in such a rush, and we all want everything to work, that there are massive incentives for all of us to say, this works, this works, this works for these medications. So even if you don't have a financial incentive, we just want our world to be better and be better quickly. So it's not just the Gilead researchers. And also when I look at these different trials, it's just so impossible without a control group in a study to try to compare to other groups because of just the heterogeneity of the people being studied. We talked about how sick they are versus not when you compare to the New England Journal article. Well, that's an important point. But even if you match perfectly for these are the exact same illness in these patients, we all know in medicine, sometimes we'll have a treatment that comes out and we want to study it. And we compare to maybe a very similar group from 10 years prior or 20 years prior. And if we show a benefit in the new medication, one of the things that we have to think about is, well, is the standard of care different? Are these patients getting other care that they weren't getting back then? And is that the difference? So when I look at, for example, the March 13th JAMA article that came out of China, I just think about the care overall that these patients were getting in Wuhan, China, when we were just figuring out what this was, compared to the care that people are getting now. And a decrease in mortality could be due to that, not just this one drug that they're quote unquote studying or talking about. Without a control group, we can't even call these studies. They're just, it's observation that people were making. And a few months difference in time, you can't match patients anymore. The standard is changing so much. So I guess the point I'm trying to make is that this is the hardest time ever in history to do a controlled trial and to have randomization and to do studies and do science well, but it's the most important time in history. So as much as I like seeing these new studies come out and the speed with which they're coming out, I'm getting really irritated just by the lack of control and poor science and published in really big journals. And I just think we've got to just have a global push to do good and better science. Even if it's a slight delay, when I really try to critically look at these studies, I have a hard time making anything of them. And I think they may be really confusing for the general public and for all of us.
I mean, even if they just basically took those, 13 patients that are still in, 12 of them are in the ICU and one of them is actually all 13 might be in the ICU. But if they just waited for them to get an outcome, it would be like monumentally more helpful, because then I would know if the mortality on this drug is 13% or 37%. The fact that they rushed to, publish the research before all the data was back is just mind-blowingly frustrating. I mean, like, I agree with your control part, but like, for the love of God, at least like get all the data before you publish your study. And that way, I mean, I could at least make some sense of it, and I can, I've been spending hours staring at this and trying to compare the different groups, and great, I can compare the groups to some extent, but not if I don't have all the data.
And obviously we can't wait forever. Like, the mortality is 100% in every study if you wait long enough. But the problem is, normally in science, like, you can release a study after a certain period of time, and everyone knows and looks at it and knows there's going to be more data coming out. And there's going to be reanalysis, and we're going to be patient. But that's not happening right now. When a study like this gets released, then everyone actually draws conclusions, instead of knowing that a study that's released early is mainly hypothesis generating, and it just helps us design other studies, but it's not an answer. And that's, right now we have so many people who are reading these studies, but not in a critical manner, that it's just never been more important to make them good and not rely on us to be able to tell what they mean when they don't really have any great conclusion to them yet. So, us ranting about studies for a few minutes. Hopefully you learned something in that. If you didn't, we're sorry. We'll do better tomorrow. The podcast going forward, we're going to be releasing one podcast a day in the morning every day. 3 times a week, it'll be kind of a COVID update, and we'll be going over some literature and updates for you like this. The rest is going to be content that we think is very important, but not direct updates with numbers. Also, we really enjoyed the summit, the Wild Health Summit, and getting to interact with so many people in real time and answer questions and have great discussions. So we're going to start doing that more often, not on a 3 days, 6 hours a day type of scale, but for an hour or so at a time. So our first webinar and Q&A session is going to be on return to play and return to work. We've been working on protocols for a wide variety of pro sports leagues, businesses, and other groups on how exactly they can get back to play and work safely. They've contacted us and just asked us to help with that. And just to be clear, we're not talking about getting back to work or play today, tomorrow, or next week. We think there are really clear metrics that must be met before this is safe to do. But to not have a framework to think about it or a plan, we also think would be irresponsible, because we are going to open back up, but we have to do it correctly. So if you want to participate, the registration for this webinar, where we want to openly have that conversation, is going to be at wildhealth.com. You can register to participate, ask questions, give us your opinion. It's open to everyone, and we're going to be discussing things like testing, the test operating characteristics, which we're just still figuring out and getting more and more data on, the risks involved of opening up versus not opening up, the security concerns, kind of human factors involved, resource management. And together, we hope to really start to get a robust plan together for when the time is right, opening the economy back and starting to get back to some semblance of normality. So register at wildhealth.com for that webinar. Join us for the discussion, and tune in tomorrow morning. Tomorrow morning, we are going to have DeMar DeRozan from the NBA on the podcast talking about mental health.
Thanks so much for listening to this COVID-19 update. Please send us your questions or follow along on Instagram and Facebook at WildHealthMD. And just to be clear, this is not medical advice. No patient-physician relationship has been established, and this resource is really for general informational purposes only. And finally, if you want to spread the word, please send this podcast to friends and family and give us a review on iTunes. Thanks again, and stay safe.